Poster number 15, presenting symptoms as a predictive factor for multiple postoperative visits in patients with intact fundoplication for GERD, being presented by Dr. Andres Schoner.
Dr. Schoner couldn't make it over from Austria, so I'm here in his place. I'm Tom Watson from Rochester. So thanks for this chance to present our data on presenting symptoms as a predictive factor for post-op visits following fundoplication for GERD. We have no disclosures. After anti-reflux surgery, some patients complain of persistent preoperative symptoms even though their fundoplication intact and GERD appears to be objectively controlled. The aim of our study was to determine if particular preoperative symptoms predict which patients require multiple postoperative visits after otherwise successful anti-reflux surgery. We looked at our single institution experience by a retrospective chart review. It included 396 patients undergoing fundoplication specifically for GERD between January of 2008 and August of 2012. Exclusion criteria included patients undergoing surgery for a paraesophageal hernia, prior gastric surgery, a failed fundoplication, and the development of postoperative symptoms such as new onset dysphagia or bloating. We categorized symptoms into groups including typical, laryngorespiratory, oropharyngeal, and digestive. 350 patients met the inclusion criteria, of which 94% underwent a laparoscopic Nissen fundoplication and 4.6% underwent a laparoscopic toupee fundoplication. 20% of these patients returned for additional visits after their initial scheduled follow-up, 54% for recurrent symptoms, 13% for persistent symptoms, and 33% for new symptoms. We found that patients with typical primary symptoms alone likely to require only the routine visits and did not require additional visits thereafter. Additional visits were significantly more common in patients with preoperative symptoms of chest pain, sore throat, and foul taste. From our data, we concluded that atypical symptoms such as those I listed were predictive of the need for multiple postoperative visits. We assumed that these symptoms were likely not due to GERD and therefore were not relieved with the anti-reflux procedure. We also believe that a thorough symptom assessment is important as we sit down with these patients prior to surgery to learn about which symptoms they are experiencing and which ones are likely to be made better or not after surgery. Once again, I thank you for the chance to present.
How did you decide which patients were getting a toupee instead of a Nissen?
That's all based on preoperative motility studies. Pretty much anybody short of really poor esophageal motility to the point of approaching aperistalsis gets a Nissen in our hands. So it's only those very few patients with very delayed esophageal clearance that we do a toupee on. So if you can see from our experience, it was under 5% that got toupee.
Mm-hmm. Great. Thank you so much. Great study.
Thank you. Alrighty, number 18. Predictive factors associated with postoperative pancreatic fistula after laparoscopic distal pancreatectomy. A 10-year single institution experience being presented by Ho Sung Han.
Thank you. I'm Dr. An. Will present this topic instead of Ho Sung Han. He cannot come because of his flight schedule. I have no disclosure. Laparoscopic distal pancreatectomy is a treatment option for benign and borderline pancreatic tumors. However, pancreatic fistula remains a significant morbidity, contributing to the length of hospital stay and overall cost. In a consecutive series of 143 patients at a single institution between January 2003 and December 2013, the predictive factors associated with pancreatic fistula after LDP were identified. We determined the thickness of the pancreas by preoperative and postoperative CT imaging based on resection line of postoperative imaging. Here is the result. Overall pancreatic fistula rate is 17% based on ISPFS. When we divided the patient into the two groups, no pancreatic fistula group were 118 cases. Pancreatic fistula group were 25 cases. In multivariate analysis, pancreatic thickness and combined parameter, which is thick pancreas with soft texture, is the significant risk factor to pancreatic fistula. So, in conclusion, pancreatic thickness exceeding 12 millimeters significantly increased the likelihood of pancreatic fistula after LDP with staple closure. Pancreatic texture alone is not an independent risk factor. However, when combined with a thick pancreatic parenchyma, a soft pancreas predicts significant risk of pancreatic fistula. Thank you.
Do you vary the stapler thickness that you're using based on the thickness measured preoperatively?
We used almost gold cartilage, echelon gold cartilage, and sometimes we use green, but almost cases used gold cartilage. Yes.
Okay. Thank you very much.
Yes.
Thank you so much. Great work.
Poster number 19, the impact of bariatric surgery on polycystic ovary syndrome, a systematic review and meta-analysis being presented by Noah Schweitzer.
Nice. All right, we're almost there, guys. Two more. So I'd first like to thank Stages for giving me this opportunity. We're all pretty excited about our research. So today we're going to present the impact of bariatric surgery on polycystic ovary syndrome, a systematic review and meta-analysis. And we have nothing to declare. So currently we're Canadian, and in Canada the indications for bariatric surgery are a BMI above 40 or a BMI above 35 with severe comorbidities. And one of them generally is not PCOS. And if you guys remember, PCOS is defined by 2 of 3 in the Rotterdam criteria of oligo or anovulation, hyperandrogenism, and polycystic ovaries. And there's this complex relationship between obesity, the metabolic syndrome, and PCOS. And it's not well elicited yet, but it's definitely multifactorial. And right now, the primary treatment modality for PCOS is lifestyle changes, so exercise and weight loss and diet regimens. So we want to see, is there a role for bariatric surgery? So we wanted to systematically review the literature to see the efficacy of bariatric surgery on the treatment modality of PCOS. So what do we do? So we searched all electronic databases, including Embase, Scopus, Medline, and we screened 311 papers by title and by abstract, and we included 13 papers which we thought were relevant to our study. Unfortunately, they were all case series, None of them were randomized controlled trials, and we'll get to the significance of that after. So it's pretty interesting results we found. So the prevalence of PCOS in these papers on average is 45% pre-op, and that significantly decreased to about 7%. And then that was maintained long-term at the study follow-up end. And all the clinical phenotypes of PCOS were also significantly decreased. So menstrual irregularity, hirsutism, and infertility. Unfortunately, infertility, there was only one study that talked about it, and that's one of our limitations that, as we know, in a systematic review, you're only as good as your primary studies. So unfortunately, there's marked heterogeneity amongst our studies. So that kind of limits the conclusions that we can make. So in conclusion, we think that it appears that bariatric surgery is an effective treatment modality. It's not a cure, and I think that's the emphasis we have to make. It doesn't cure polycystic ovary syndrome, but its phenotypes definitely improves. And one of the interesting things and the exciting things is maybe this is a new indication for bariatric surgery. It can be one of the severe comorbidities. All right, thank you guys.
Thank you so much. Again, I encourage you, you did so much work with this meta-analysis. Please publish this, because you're right, it's very frustrating to have somebody who's a BMI 39.8 and the insurance doesn't cover it because they don't recognize polycystic ovary or reflux or anything other than sleep apnea and diabetes, and really some hypertension is comorbid conditions. So please, too much work not to publish it.
Especially, I was just going to say, especially the infertility one for reproductive women is a big deal. So, I mean, maybe they're BMI of 39, but maybe they want to have a child. So it's, if that can improve infertility, it's important. Thanks, guys.
Thank you.
Very good. Thank you. Our closer, bringing in the home runs. Poster number 20, prospective trial comparing laparoscopic gastric banding with plication versus laparoscopic gastric banding alone, being presented by Arif Ahmed.
Hey, Arif, how are you?
Good afternoon. Thank you for the privilege of addressing you, and thank you for staying till the sweet end. Next slide, please.
I'll be happy to do it for you if you'd like.
Okay. So the purpose of this study was, we had a prospective trial comparing the outcomes of the addition of greater curvature plication to laparoscopic gastric banding alone. So we conducted the study prospectively, with IRB approval. Everything was done, with informed consent that we were trying out a new procedure, and basically a variation in a procedure that was already established. And we were trying to assess whether this improved weight loss, whether it increased complications, etc. So we had 194 patients, and we divided them 95 of them had banding alone, and 99 had banding with plication. Now, this is a non-randomized study. So basically, patients selected, themselves, and they said, we offered this to all patients that chose to have a band, and then some patients wanted to have this addition of plication, and some did not. We collected data on operative times, complications, number of band adjustments over 3 months, 6 months, and 12 months, and also percentage excess weight loss over 3 months, 12 months, and 24 months. In fact, we started this study in 2011, so we have much more data, but this is what we're presenting right now. And because at the time we wrote this, we didn't have all the, we didn't have all the follow-up, et cetera, ready for presentation. So those are our results. In summary, what we found was that mean excess weight loss, the mean, percentage excess weight loss was higher with the plication group. So those who had the band plus the plication, they had a higher mean excess weight loss, both at 3 months, 6 months, and 12 months, as well as 24 months. But this reached significance only at 3 months, 6 months, and 12 months. I want to back up a little bit. I meant to also show you how we did this procedure. So you can see the way we did this procedure is we performed a standard lap banding. As you can see, is there a pointer here? This is a pointer, okay.
There's one there, and this one's brighter.
Okay.
Yeah.
So we did a standard lap banding as you would normally do up there, okay? And then we mobilized the greater curvature. we started the mobilization 5 centimeters from the pylorus, and we went up to complete the mobilization right to the site of where the banding had been plicated. So the standard anterior wall plication that we normally do. And then we put 2 layers of interrupted sutures. The first layer was interrupted, and the second layer was a continuous suture. There were non-absorbable material used, and we had a bougie. We basically used the lab band calibration tube, which is 13 millimeters in diameter, which comes to a 39 French, just for equivalence. Everything else was the same in terms of the procedure itself. We also found that in terms of complications, we had no perioperative complications in either group, and we had no returns to the OR or anything else in either group. We found that the operative time was higher in the group that needed the plication as expected, and we found that the band adjustments was higher in the band alone group. So basically, patients who also had a plication needed less adjustments. Either they didn't ask for it, they felt they were satisfied, they were more, the hunger was better controlled, and then we noted that the complication that was increased in the group that had that did not have the plication was that there was an incidence of slippage. We had 3 bands that had slipped over this period of 2 years in the patients that did not have application, and in the patients that did have application, there was no slippage in any of the patients. We'd like to conclude that in our study, the addition of greater curve plication to banding is safe and effective, and that the excess weight loss is superior at 3 months, 6 months, and 12 months. And at 24 months, it did not reach significance, but that was because we had a loss of follow-up. We had a decrease in population size from 12 months to 24 months, as you can see. We believe that longer-term follow-up is necessary to more completely assess the complications and the durability of addition of greater curve plication.
Great.
Thank you for your attention, and I'd like to take any questions.
Thank you. Any questions from the audience?
What do you think about doing plication alone?
You know, I think that since we have the sleeve, I really believe that there's really not great advantage in doing plication alone. And I think if you have to do anything later on after the plication, it just makes subsequent surgery more difficult.
Okay. Great. Thank you very much.
Thank you so much. Thank you.
Thank you, everyone, for staying to the
bitter
not
end.
bitter but sweet end. And I hope you enjoyed your SAGES meeting. It was a pleasure having you here. We look forward to seeing you in Boston next year.
Thank you all again. Excellent jobs.